Welcome to this explainer. Look, today we're taking some of the most incredibly dense medical physiology out there and transforming it into clear, actionable clinical reasoning. This is for your exams, sure, but more importantly, for your daily practice. So let's jump right in, because honestly, understanding exactly how fluids and electrolytes move in the human body is quite literally the foundation of saving patient lives. Here's a quick look at our roadmap for today. We'll be covering fluid homeostasis, core compartments, key electrolytes, fluid movement and IVs, and finally, clinical applications.
Section 1, Introduction to Fluid Homeostasis. We're going to start by establishing the absolute, most fundamental baseline rule of the human body.
And that rule is the relentless, unending drive for balance. Your body is continuously working behind the scenes to maintain a perfectly stable internal environment. Whenever fluid or electrolyte levels deviate from normal, whether they spike into a dangerous excess or plummet into a severe deficiency, your body's corrective mechanisms immediately kick in to restore that vital balance. This self-regulating cycle is literally the bedrock of homeostasis. And our job as clinicians is to step in exactly when those natural mechanisms fail.
Now, accurate documentation is a massive part of nursing. To know if your patient is balanced, you've got to measure what goes in and what comes out. That means accounting for the really obvious, measurable fluids, like oral drinks, IV solutions, and urine. But you also have to be acutely aware of the hidden stuff, the non-measurable factors. We're talking about metabolic water produced internally and insensible losses like sweating and lung vaporization.
So how does the body actually fix a deficit when it happens? Well, when your fluid volume drops, or the concentration of your blood rises, this chronological sequence is basically your body's first-line defense. First, your hypothalamus stimulates osmoreceptors, and that triggers a decrease in saliva and that unmistakable, intense sensation of thirst. You drink, the fluid is absorbed from your GI tract, and boom, your extracellular volume is fully restored.
Section 2. Core fluid compartments. Now that we understand that primary drive for balance, let's map out exactly where all this fluid actually lives inside the body.
Get this, about 60% of a healthy adult's body weight is just pure water. Understanding how it's divided up is absolutely crucial for anticipating how IV fluids are going to shift once you hook up a bag to your patient.
So here's the breakdown. The vast majority of your fluid, making up about 40% of your total body weight, is tucked securely away inside your cells. We call this intracellular fluid, or ICF. The remaining 20% is your extracellular fluid, or ECF. That makes up the plasma inside your blood vessels and the interstitial fluid resting between your cells. And the ECF is what we are routinely accessing with our IVs and monitoring with our blood draws.
Section 3. Key body electrolytes. Having mapped out the territory and the compartments, let's populate them with the key players.
These are the electrically charged minerals that keep our muscles contracting and our nerves firing. They're classified by their electrical charges, right? Positive cations and negative anions. And what's really fascinating is that they are highly compartmentalized. Keeping them separated into these specific indoor and outdoor cellular zones is what preserves the electrical neutrality of your body fluids. Inside the cell, potassium, phosphate, and magnesium absolutely rule. Outside the cell, sodium, chloride, and calcium take charge.
I want you to pay extremely close attention to these two heavy hitters right here. Potassium, which lives in that incredibly tight normal range of 3.5 to 5.0, directly regulates your cardiac muscle. Even tiny deviations here can cause life-threatening heart dysrhythmias. On the flip side, sodium, living between 135 and 145, dictates your water distribution. If you take nothing else away, remember this golden rule of physiology. Where sodium goes, water always follows.
Section 4. Fluid movement and IVs. With our electrolyte players established, let's look at the cellular transit system.
And to understand that transit system, we have to talk about osmosis. This is the passive driving force where water moves from an area of lower particle concentration to an area of higher particle concentration. It is always trying to dilute the concentrated side. Osmosis explains exactly how the tonicity of the IV fluid you hang will actively affect cells throughout your patient's entire body.
And what dictates that movement? Your serum osmolality. This number right here, 280 to 300 milliosmoles per kilogram, is the perfectly normal concentration of particles in your blood. Honestly, your kidneys and hypothalamus are constantly, obsessively monitoring this specific number to decide whether to hold on to free water or excrete it, just to keep you right in that sweet spot.
But, as we know, sometimes fluid ends up where it shouldn't. First spacing is totally normal.
Second spacing is the abnormal accumulation of interstitial fluid. That's what you'd see as peripheral edema. But third spacing, that is particularly dangerous. This is when fluid shifts into a compartment where it's trapped and functionally inaccessible, like ascites in the abdomen or a massive swelling from severe burns. The really scary part is that the patient might visually appear hugely fluid overloaded, while their actual usable blood volume inside their vessels is critically, dangerously depleted. So this table is essentially your ultimate clinical cheat sheet for safe IV selection. It details exactly whether a fluid will leave a cell alone, swell it up, or shrink it down. Isotonic fluids have equal osmotic pressure to your blood. Hypotonic fluids have a lower concentration, forcing water into the cells. And hypertonic fluids have a higher concentration, aggressively yanking water right out of the cells. Visually, you can see exactly how this plays out. Over on the left, isotonic fluids like normal saline provide safe volume replacement. They boost blood pressure without forcing water into or out of the cells. But take a look at the hypertonic solution on the right. Notice how the arrows point outward? These heavy, solute-packed solutions pull water out of the cells and directly into the vascular space, causing the cells to actually shrink. You'd only use that very carefully in critical situations for things like severe cerebral edema.
Section 5. Clinical Applications and Imbalances. We've covered the basics. Now it's time to transition from basic science directly into active, high-stakes, clinical reasoning.
Let's kick this off with a scenario. Think about your patient presenting with this specific lab value, a sodium level of 151. Normal tops out at 145, right? So this is hypernatremia. What dietary counseling must you immediately provide to manage this dangerous excess of sodium?
Because their sodium is so incredibly high, it usually indicates a relative water deficit. You need to be super aggressive about restricting these hidden dietary sodium traps. We aren't just talking about taking away the salt shaker on their tray. We're talking about cutting out canned soups, processed chips, deli meats, and soy sauce, all while ensuring we increase their free water intake to help dilute that blood back down to a normal osmolality.
Okay, let's move to another key concept and see how this builds your critical thinking. Electrolytes do not exist in a vacuum. If one lab value is heavily abnormal, you need to proactively anticipate what the other electrolytes are doing, ideally before the lab even prints the results.
The crucial point here is memorizing these distinct relationships. Sodium and chloride, they are basically best friends. They move proportionally together. If sodium spikes, you should absolutely expect hyperchloremia right behind it. But calcium and phosphate, they're on a seesaw. They have an inverse relationship. If a patient's calcium dramatically drops, you must anticipate and be on the lookout for an elevated phosphate level.
Pulling it all together with the physical exam, the warning signs are night and day. Tachycardia, hypotension, a dry mouth, and oliguria, which means low urine output, these all scream that the tank is completely empty. It's a severe fluid deficit. Meanwhile, things like jugular vein distension, abounding 4+ pulse, and non-pitting edema point directly to a fluid volume excess. Your bedside assessment is the ultimate key that unlocks this data.
And that brings us to our final takeaway. Rote memorization of lab values? It's just not enough to be a great clinician. Are you integrating all these cues to see the true clinical picture? Because combining these foundational concepts of osmosis, spacing, and electrolytes with your hands-on physical assessment is what truly saves patient lives. So I leave you with this. The next time you hang an IV bag, ask yourself, do you actually know exactly where every one of those molecules is going? Keep learning, keep assessing, and I'll catch you on the next explainer.